So what we're going to go through now is carpal mobility and stability testing. Okay, so let's go through real quick some of the biomechanics of the hand. Okay, so coming from full flexion, as we start to move toward extension, right at neutral flexion extension, so right when the wrist is at complete neutral, what happens is the distal row will close pack on the scaphoid. Okay, so right at that point, the scaphoid is going to lock up and become part of the distal row. Okay, beyond that, moving into extension, the rest of the distal row is going to close pack on the triquetrum and lunate. Okay, so just into extension, distal row will close pack. Now we have the carpus as one solid mass moving on the radius and ulnar disc. Okay, as we continue to move backward into full extension, the carpus will then close pack on the radius. Okay, so that's biomechanically what's happening there. Now, we also have to consider, much like the foot, that when we move into a flexed position, the hand is going to fold around a central column. Right? So the central column will include the lunate, the capitate, and the third metacarpal. Okay? Now, as we're looking at this, we should be considering this based on the anatomical position, right? So as this occurs, the the radial side, right? So the lateral side of the hand is going to internally rotate, right? Rotate toward the midline of the body. While the lateral hand will externally rotate, right? Away from the midline of the body. Okay, so that will include the hamate and the triquetrum for the medial side of the hand, scaphoid and the trapezii for the lateral side of the hand. Okay, now just the reverse of that will happen going into extension. The hand will fan open. Okay, that means as we move into this position, we get an external rotation of the scaphoid and the trapezii, an internal rotation of the triquetrum and the hamate. Okay, around that central column. So, why do we need to know this? Well, essentially what that does is it helps us bias our position when we go through to do mobility testing or stability testing, right? Because what we have to assume, same as with the foot, is that we understand the angle of the joint, right? And if we're dealing with a position here, the angle between, say, the trapezoid and the capitate is going to be different than it will be if it's in full extension. Okay, does that make sense? Why we have to consider that? Okay, so if we want to look at stress testing, we would take the wrist into extension, right? We don't have to be in full extension, right? We just need to be in enough extension to close pack the carpals on each other. All right, so I would say if we're into maybe 15 degrees of extension, we're probably in pretty good shape. And then all we're going to do here is we're going to landmark. We're going to grasp, that's probably better. We're going to grasp the trapezoid on the scaphoid, and we're going to shear the joint, palmar and dorsal. Okay, lunate on the capitate, palmar and dorsal. Triquetrum and the hamate, palmar and dorsal. Again, maintaining extension of the wrist. Okay, that is for the frontal plane joints. Okay, then we would have to consider, although these are less common, most commonly problems are the sagittal plane joints. So this would be the trapeziae on the capitate, scaphoid on the capitate, scaphoid on the lunate, hamate on the lunate, and triquetrum on the lunate. Sorry, hamate on the capitate, triquetrum on the lunate. Okay, so that's our stress testing for the intercarpal joints. And what we should find is we either get a reproduction of the patient's reported symptoms at a particular intercarpal segment, or we find laxity. I'd say probably the most common one is the lunate being unstable. There's actually a term for that, and I forget what it is. Ballottement? Is that what I'm thinking? I think it's ballottement. Okay. Now, if we drop them into flexion, now we're in a loose pack position. We can test scaphoid on capitate, scaphoid on lunate, trapeziae on capitate, hamate on capitate, triquetrum on lunate. Okay, those are our sagittal plane joints. We'll go back and test our frontal plane joints. So trapeziae on scaphoid, capitate on lunate, and you can probably see how now my hand is actually moving, right? Actually getting more movement between these. And then hamate on triquetrum. Okay, and this can still apply even if we move on to the metacarpals on the carpals, right? So third metacarpal on the capitate, fourth on the hamate, fifth on the hamate. Now the fifth is like the foot, right? It's got a lot of swing, kind of like the fifth metatarsal. Now the one that's kind of the exception here is the second metacarpal on the trapezoid. This is a very deep, very stable joint. So the problem with it is getting deep enough on the palmar side to get onto either the trapezoid or the base of the second metacarpal. It's just not really going to happen. So the better choice here is actually to fixate the trapezoid and try and traction the second metacarpal. This joint will jam up on people once in a while. It's happened to me once. It is a pain in the ass to fix because it's so deep, right? Because what will tend to happen is the second metacarpal will sublux palmarly on the trapezoid, and what we'll get is this really deep depression here right in the middle of the hand. And so what we would have to actually do then is we'd have to get on the palmar aspect of the second metacarpal to thrust it back dorsally. Really not easy to do with our typical whip techniques that we're going to show you. So what I ended up having to do with this one, I took this thing, set it on the table, jammed my hand down on the top of this, and then I thumped the trapezoid. And it worked. And it hurt like hell. But it did the job. So that was the only way I was able to fix that thing. I don't recommend doing that to yourself if you can avoid it. So that's kind of the process here. Now you can do the exact same thing for the scaphoid on the radius, right? We fix the radius, dorsal and palmar glide of the scaphoid, fix the radius, dorsal and palmar glide of the lunate, fix the ulna now, and we can produce a dorsal and palmar glide of the ulnar meniscus, and then we would have to slide just distal. Again, now we're fixing the meniscus, and we would produce a dorsal and palmar glide of the triquetrum on the meniscus. Okay, but again, we just need the wrist flexion to produce this.
What is the difference in what you're looking for between the closed pack and the open pack?
Open pack is mobility testing, so I'm looking for movement, right? testing my end field. And in extension, we're doing stress testing. So we're looking for no movement, hopefully no movement, or potentially a reproduction of pain. And it should be pretty definitive, right? So let's say that I have an instability or an irritable hypermobility between the, let's say the capitate and the trapezoid, right? So if I take the patient's wrist into extension and I take the capitate and I press palmarly, they say, that hurts. Okay. What I would do then is I would move to the lunate and stress test the lunate on the capitate, and they say, no, that doesn't hurt. Then I would move back to the trapezium, go to the scaphoid, stress test that, and they say, no, that doesn't hurt. Now I know it's the ligament, likely in between, or the joint capsule, some of that soft tissue structure in between the capitate and the trapezoid that's actually breaking down and has become irritable. Because that can give me now a target for cross-friction massage. Because you can actually fix those up pretty nicely with cross-friction massage. Now, cross-friction massage, I'll tell you this right now, on the intercarpal joints is really difficult to do with a finger. So the best thing that you can use is actually a pencil eraser. Hopefully a new one, not one that's all worn down to the nub where you're going to dig the little piece of metal on the back end of the number 2 pencil into the back of somebody's wrist. But that does work pretty well. It actually will help stabilize it, it will desensitize it. But you just kind of have to figure out what set that off in the first place. Typically those instabilities are a result of what they call carpal dissociation. And probably the most common cause of that is that distal shunting of the radius. It'll push into the wrist, it'll start twisting things up, and then it'll start moving those carpals around in various positions, and that'll start to break down those articulations. Could happen traumatically, you could have a fall, something like that. But those should be very point-specific pains. They say, where does it hurt? And they're going to be like, it's right here, or it's right here, something like that. And that's very similar to the foot as well. Right. I've had patients come in complaining of dorsal foot pain, and what we ended up finding was they had a dropped lateral cuneiform. Right. Do the manipulation, do a little transverse friction in between that and the middle cuneiform, and they're off and running. Literally. Okay. Any questions about that stuff?